and we try to figure out the most important points related to the exam. And we like to know your your discussion, which is very fruitful and useful for us. So this pediatric patient, frontal abdominal radiograph, and Ala, welcome. So when you are talking about pediatrics, so focus in the differential diagnosis of pediatric patient. So how we describe what you see? Yeah, absence of rectal. You can see that there is absence of rectal gas, and the most important here that you can mention that there is marked gaseous distension and dilatation of the bowel loops. So what it will be your differential diagnosis in this case? So let's check if you are talking about, you can describe it like this obstruction, right? So in the neonate or the pediatric age group, you will put two differential. Is it high or low, right? Is it high bowel obstruction or low bowel obstruction? So if it is high, maybe you will mention in your differential, which is very important, the mid-gut volvulus, duodenal atresia, and duodenal issues, or pancreatic, like annular pancreas and jejunal atresia, and so on. Okay, but if you are low, I see that welcome Khalid, Justina, Abbas. Okay, yeah, you will talk about something low. So either anal, like anal atresia, perfect, and colonic atresia. I see also Hirschsprung, perfect. So Hirschsprung also it will be very nice differential, and maybe some others like meconium plug or ileal atresia and meconium ileus. So this is the big differential. Your approach is to differentiate, is it high obstruction or low obstruction, right? So if I show you this appearance, I think now it will be more characteristic of, you can see that there is this barium enema. And what happened here, how we describe what happened? Yeah, so there is transition point or transition zone, which you can see the caliber and suddenly change it. And yeah, enlarged caliber in the sigmoid, then it reduced when it go down. So yeah, reversed direct to sigmoid ratio. So now it is going more to be what you want to mention. It will be Hirschsprung, right? Yeah, Hirschsprung disease. And as you know, the Hirschsprung is like failure of ganglionic cell to innervate the distal ileum, the distal colon, sorry. So the colon in this area will be smaller in caliber suddenly, because this area it will be, yeah, narrowing Hirschsprung, perfect. So tooth appearance, this is good sign. Justana, yes. Asma, also close sign. Okay, so this is what's called Hirschsprung. There is one rare differential, is called total acolonic agangliosis. Yeah, aganglionosis, which is a bit like similar to microcolon. Sometimes they like to show you, but it's not common, it's rare. How you differentiate between this and Hirschsprung? Yeah, by biopsy, okay. How you differentiate it? by radiological appearance. Yeah, it is, as you see, it is like microcolon and no transition point. Yeah, no transition point. So this is the, again, Hirschsprung. So this is Hirschsprung, and we mentioned small in boys, and as you mentioned, this is. So this is the differential of flow obstruction, and the description you should mention in your description, no gas. The differential diagnosis will be the differential of flow obstruction, meconium ileus, meconium plug, and clonic atresia. Welcome, Marwa. Let's go to this case. We just start with the starter, then we can go more further in, yeah. Okay, it's coming, Fauzi. Welcome, Dr. Fauzi. It will come. I think it will come soon. Okay. So what do you think? Yeah. Why posterior mediastinal mass? Perfect. You remember when we talk about the paratracheal and paraspinal stripes? You remember, and para-aortic and so on. You remember this, and anterior and posterior junctional zones. So here, if you make tracer for the right, yeah, paraspinal, you will find that it is widened, and I think also, yeah, the right cardiac border, you see it is clear, so no silhouetting. صح؟ لا, perfect. So no silhouetting, retrocardiac, so it is posterior mediastinal. In this age group, your top differential will be neurogenic tumor. And what is the one of the most common tumors that, neuroblastoma. Yes, perfect. Sure that you will put other differential with neuroblastoma, but neuroblastoma, Khalid, yes, new star here. Welcome, Khalid. So in the lateral, it will be more easier to detect that is posterior mediastinal. And your differential, sure that you will involve if you go to the CT. Yeah. So when you describe it in the CT, what is the most important term that if you miss it, if you are in the exam, you will lose some marks? If I show this and you will write your report. Yeah, perfect. Ala. So don't forget to mention the intraspinal, the foraminal extension. Yeah, intraspinal extension. Perfect. So the neuroblastoma can be in the thoracic region, right? And if I show you the MRI, again, don't forget to mention the foraminal extension. So they mentioned that 40% of the mediastinal masses in pediatric, it can be posterior mediastinal, it can be a neuroblastoma. Yes. So the differential will be neuroblastoma, ganglioneuroma, and ganglioneuroblastoma. And also you can include, if you want, you can include some, if it is small, maybe you can include neurofibromas, and if it is extramedullary hematopoiesis, lymphadenopathy, but this appearance is more to be neurogenic tumor, especially with intraspinal extension. Yes, then they have much question about neuroblastoma, especially about the age. So which age group is specific it likes? And is it affecting the behavior of neuroblastoma or not? So usually the age is less than 2 years. Perfect, 2 years, yeah. And if it is more than, 2 years. So less than 2 years, and if it is less than 1 year, is it good prognosis or bad prognosis? MCQ questions. If it is less than 1 year, Is it a good prognosis or bad prognosis? Yeah, it is good prognosis. So they like to mention that, yeah, and when it is not metastatic, it is have favorable outcome. If it is metastatic, then it is poorly prognosis, with poor prognosis, will product in poor prognosis. Yes. So the most important modalities you will use in neuroblastoma and diagnosis, the best of choice will be, it will be what? No, yeah. I show you MRI to be tricky for you. It's not MRI. The most important MIBG, the gold stone of the diagnosis, MIBG, because it have noradrenaline, norepinephrine. So it's the most important MIBG. But the MRI is it's very important. If you have it, is good, and CT and ultrasound before all, because this is pediatric age group. You will start with ultrasound. Okay, but the most important here, it will be MIBG, and some of the neuroblastoma, they didn't take MIBG, but this is not the common. Maybe then you can use FDG, PET-CT, and so on. Okay, so let's have a look in some important details about neuroblastomas. Is important in the exam to know about it. They like in the exam, especially in MCQ, and to know which if it is metastatic, then it is bad prognosis, and it like the bone, metastatized to the bone mainly. Yeah. Okay. Let's shift to another case. Yeah, when you see X-ray pelvis, then you have limited differential diagnosis, and you should be ready, because if you go in any pediatric committee for exam, they will show you the pelvis as ABC pediatric musculoskeletal. So you have, yeah, you have limited differential, either DDH or yeah, you have your limited differential. Let's talk about it first, then we'll go further. So your differential will be very limited, and one of the, I see a lot nice that you think about, yeah. So the pathology in the left or the right? Left, Marwa. So the left fat planes obliterated, and the left hip joint is widened. Yeah. So the most important here will be the, which modality is the most important here you will use if you suspect what you mentioned, ultrasound. Perfect. So the most important here, the when you suspect septic arthritis, to go further to ultrasound to preserve this joint before it go complicated. It finished. Yes. So this girl with the left hip pain, you can see that there is some displacement of the left femur, as you mentioned, yeah, and there is some joint widening. And when you suspect that there is some joint effusion, then you are going to be effusion and septic arthritis. Marwa, Sarah, perfect. Yeah, Marwa, yes. Sarah also, yeah. So, yeah, okay. So, septic arthritis, like the big joints, children, staph aureus, you know this, route of spread, metaphysis, then epiphysis and joint space. and maybe it can come from direct spread and from adjacent osteomyelitis. Okay. The most important will be ultrasound, and yeah, it can be in shoulder as well. So look, when it is in the shoulder, where is the abnormality? Is it right or left? Yeah, it looked like that the right more affected, yes. And it looked like the right, yeah, widened. And when you do the ultrasound, okay, again, you can see the septic arthritis, and you can see the appearance difference between the right and the left. So very important to be in your differential, yeah, when you suspect effusion, and to go for ultrasound and make aspiration. Yes. Let's go to another case. This is frontal radiograph of chest and abdomen. How we describe it? So you suspect that maybe something in the abdomen with this tumefaction appearance, white abdomen. So you think that maybe mass, ascites, bowel. Yeah, you will think about many differential, right? Maybe bowel displacement. But you suspect that maybe something in the right upper quadrant and there is some displacement. I see that Marwa already mentioned that maybe something in the liver. Yeah. I am waiting all description. I see that all description going to the abdomen, right? Ala, perfect. So don't forget the upper. So there is a cardiomegaly here, right? So you are going with two findings at least. Cardiomegaly, and there is abdominal pathology. Look like there is two pathology, one in the cardiac shadow and one in the abdominal shadow. So now what is your differential? When you see pediatric patient, yeah. Now is easier one. So we mentioned this in the previous session. When you find the cardiomegaly and you find like tumefaction or soft tissue mass in the abdomen, making displacement of the bowel loops. So you are talking about differential, and this differential should include hemangioendothelioma. Why? Because the shunt will make the cardiomegaly. Yeah. And when you do ultrasound as a first modality you'll use, you can find in the liver that there is hypoechoic mass lesion going through the abdomen. And if you do CT, you will find this appearance. So maybe the appearance is not very characteristic to be something, but it can be like hemangioma or others. And in the pediatric age group will be what is called hemangioendothelioma. And it can be large like this appearance. And you can see the enhancement pattern. So the most important, Marwa, perfect. The most important, as you mentioned, the age. Yeah. When you suspect this in the age, especially with, if he gave you the clue like here with the cardiac appearance, so you are going to mention that it will be the hemangioendothelioma. So do you expect here the alpha fetoprotein? We mentioned this high or no? No, perfect. So when it was high, when you find it high, you will suspect which tumor? You will suspect it. you will think about which tumor? Hepatoblastoma. Perfect. So when you find the alpha fetoprotein high, but you should be more accurate, you can say less than, for example, 5 years, you are talking about hepatoblastoma. But if it is more than 5 years, then you are talking about HCC. So to be more accurate, alpha fetoprotein in pediatric age group, in older one or is younger one. If younger one, yes, you are talking about hepatoblastoma. Okay. So again, hemangioendothelioma. Let's talk about it. It's like the girl is more less than 1 year or 6 months. You can say 6 months even, and it can have, as you see, the hepatomegaly and congestive heart failure. And there is one syndrome, they like it in the MCQ. Do you remember it? Which make the destruction of RBCs.
Kazabach-Merritt syndrome.
Perfect. Who's the welcome, doctor? I don't know, but thank you. Kazabach-Merritt, which have thrombocytopenia. Fauzi, yeah, welcome. And you can see that you can say that it is yeah, association with it. They like the MCQ. Okay. So infantile hemangioendothelioma have many, and the most important differential will be hepatoblastoma. And check the previous session, you will find the case we mentioned it already. Okay. So again, mass, well-defined border, yeah. So here,
hepatoblastoma.
Hepatoblastoma, perfect.
Because
Again,
it is because of calcification and solid mass.
Yes. So the rule, as we mentioned previously, that if you find mass with calcification or mass, even solid mass in the liver, it is hepatoblastoma in pediatric age group. It is hepatoblastoma until proved otherwise. Yes. Especially if you find the alpha fetoprotein is high. Okay. Many appearance of hepatoblastoma, and the calcification is about 50%. So you can find 50% of these cases with calcifications. The association of hepatoblastoma will be with many diseases. Can you mention anything you remember?
Hemi-hypertrophy مع الويلمز.
Wilms, perfect. And hemi-hypertrophy. Also, it can be Beckwith, Widman, and Gardner. Yeah, Beckwith, perfect. So they have also some association they like to mention in the exam, and the management will be different from the hemangioendothelioma, either resection or maybe if it is metastatic will be multi-modality treatment, agent treatment. Okay. And let's go to the liver, and the third one, which have in the pediatric age group. If you find in the ultrasound like this, and you are lucky, man, you can mention it. So how you describe it if you find the ultrasound like this?
Multilocular cystic mass.
So you can say solid and cystic. Yeah, there is some cystic component and there is large solid component. Yeah, and this inside this solid component there is cystic it changes, or cystic, another smaller cystic component. And what about the color? Justiana, I hope that I pronounce your name well. Yeah, perfect. Yeah. So this is what is called hamartoma. Color Doppler demonstrate prominent vascular flow in the mass. Yeah. And if I show you the MRI, so this is what is called mesenchymal hamartoma. Can you describe it in the MRI? In terms of T1, it will be like low signal, and you can see that there is multiple rounded areas. And yes, here, and in the T2, you can see that there is high signal in T2 with fat suppression. Yeah. So you are going to mention that is have cystic appearance, right? So this is what is called mesenchymal hamartoma. It can be big mass like this, but sorry, it can be big mass, but benign one. Okay. Let's shift again to GI. Then again, when you find how you describe it first, describe this appearance in one
Multiple,
yeah, dilated bowel loop.
multiple dilated bowel loop
Perfect.
with
So you are
absent air in the rectum.
Yeah, so you are talking about obstruction, right? Then it is
Distal
low
bowel obstruction.
or
It is
high
a distal.
obstruction. Yeah,
It is distal obstruction.
yeah. So it is distal obstruction. So what is now your differential diagnosis? We mentioned it. What is this? What it will
Meconium ileus.
be? Meconium ileus. Perfect.
Ileal atresia.
Ileal atresia. And we mentioned
Total Hirschsprung.
Hirschsprung. We mentioned it. And meconium, finally meconium blood or small left colon syndrome, right? So this is your probably your 4 differential, yeah. And you can add any atresia, anal or colonic, yes. Dr. Rabab, perfect. So what do you think about this? Which one you would choose? Do you need anything to help you?
Barium enema.
Perfect. So this is what yeah, enema. So you need this one. Then now your differential will be much easier to know what it could be, right?
Meconium ileus.
Yeah. So how you describe it? You describe that it is microcolon, right? Yeah, and you will find some filling defect within. So this filling defects.
The right hemicolon.
Yes. So long microcolon or short microcolon, it is like long microcolons, right? Long one, perfect. So long microcolon, you are talking about either meconium ileus or distal ileal atresia. So how you differentiate between both? Now we are talking about category. Low obstruction, yes. Now we differentiate between low and high. Now we are talking about low obstruction. Low obstruction, you have 2 issues, either short microcolon or long microcolon. So this one look like long microcolon, right? Okay. So long microcolon, either meconium ileus or distal ileal atresia, right? So what do you expect in the distal ileal atresia? There will be no contrast will reach what? What is closed? The ilial loop. So it will be the contrast will not pass to the ilial loop, right? Perfect. So how differentiate it from the meconium ileus? Yeah, the contrast will reach the ilial loops. Perfect. Yeah, that's what I need just to know, either in the image or the MCQ, which is much more important. Which one is associated with cystic fibrosis? You can say that most all cases will be with cystic fibrosis. Which one? Meconium ileus. So meconium ileus is the one with cystic fibrosis, is the one with multiple or filling defects because of the meconium, and is the one that the contrast will reach the ilial loop, long microcolon. the differential diagnosis with either meconium ileus or distal ileal atresia. And we mentioned that the meconium ileus, which is long microcolon, will have, yes, the cystic fibrosis patient type and some filling defects. And finally, yeah, the contrast can reach the ileal lobes. Okay, so this is what is called meconium ileus, almost associated with cystic fibrosis, as you mentioned. And yes, the complication, it can end in peritonitis, and you will search in the X-ray for any free air. Okay, we cannot figure out any free air in this case, or free fluid in the abdomen. The most important to try to differentiate the contrast enema. So if you find this long microcolon and there is some filling defect in the ileum, so you are talking about meconium ileus. Okay, is it clear? So what do you think about this one?
Meconium peritonitis.
Yes. Why do you mention that it could be peritonitis?
Pseudocyst.
Can
Yeah.
calcified life mass right hypochondrial.
Peritoneal calcification.
Calcifications, perfect. Because as you know, that it will be like chemical peritonitis, sterile chemical peritonitis, and it will end in formation of calcification. So Ala, Justiana, perfect, Rabab, yeah. So, and good to mention that it can reach the scrotum as well, as in this case, because there is the processus vaginalis have like intra-communication with the peritoneum. Okay, so anyway, it can also, let's see this case, it's another case.
Necrotizing enterocolitis.
What?
Necrotizing enterocolitis. أنا شايفة إن في air
Yes, perfect. So why do you mention this?
air on both sides of wall و free air في ال
Free air?
peritoneum.
Yeah. And when you just find any free air, your concentration will be to look in the
portal venous gas.
So look in the first approach, you will find any free air. Go directly to see if there is any portal venous air. Okay. So yeah, necrotizing enterocolitis, any free air in the abdomen, your differential will go to be necrotizing enterocolitis. It can be idiopathic. Your type of patient will be premature or mature patient, term or preterm.
Premature.
So the most important, to mention that it's premature. Dilatation of the bowel loops, okay. Search for the portal venous gas, the most important to know, okay. This one, when you find it, you can describe it, try to describe. Yeah, epiphyseal. So the most important to mention the term, then try to find the differential diagnosis. So epiphyseal, Nermeen, nice, perfect. Epiphyseal.
Fragmented epiphyses.
Perfect. So epiphyseal fragmentation. Then I see many differential, very nice differential, including
Hypothyroidism, drug-related.
Yeah. And EVN as well, births. I see many very nice differentials. Yeah, juvenile rheumatoid arthritis as well. So this is what is called irregular stippled epiphyses. Just to know, that it have many appearance, you need to put your differential. When he show you the spine as well, yeah, congenital hypothyroidism, yeah, it can be like this one, hypothyroidism, perfect. When you see the involvement of the spine,
Spondyloepiphyseal.
epiphyseal dysplasia.
yeah, from the name you can know it's spondyloepiphyseal dysplasia. Yeah. Okay. So again, epiphyseal involvement, and it will be differential diagnosis. But when you involve with the spine, you are talking about a spondyloepiphyseal dysplasia. Okay, let's shift to another case, important pediatric.
Sacral agenesis.
Okay, so you start with the sacral agenesis, perfect. And what is your thinking about now after you mentioned that the sacrum
Caudal regression syndrome.
caudal regression syndrome? Yeah, perfect. So this front radiograph, the vertebral body is okay, but after that you cannot find the sacrum, and also the iliac bones, they are yeah, so this is like deformed pelvis, no sacrum. Your differential asthma, nice, okay. I'll try to come back to this case. It will be caudal regression, yes. If I show the MRI, how we describe it?
في واحد abrupt termination. هما دول types، واحد type D1 type 2.
Okay.
Truncated cord.
Yeah.
It's called truncated
you
cord.
mentioned that the cord is low lying, right? So what is called this when you find that the cord is low lying
كسر.
below? Yeah. Below what? Which vertebra is abnormal if you find it below what?
Below inferior end plate of L2.
L2, perfect. So when you find below L2, it is what is called tethered
Cord.
Yes. So when you find tethered cord, what you will search for? You will search for fat. Search for fat. Yeah, Justiana, perfect. When you find tethered cord, search for fat. When you find fat, search for tethered cord. Okay. So when you find one, search for the other. Then you can reach the caudal regression syndrome. Okay. So what is caudal regression syndrome? Something like dysplasia or dysgenesis happen in the lumbosacral vertebrae. So the distal spinal cord, there is abnormality. The type of patient will be the diabetic mother infant, right? So either you find absent coccyx or maybe absent even lumbosacral. And as you mentioned, there is group 1 and group 2. And when you find the elongated conus with tethered cord, search for lipoma, intraspinal lipoma as here. Okay? And the type 1 will find just the tethered cord with central canal maybe prominent. The most important association, they like in the MCQ, what it will be? Two important association. The first association will be bacterial, perfect, bacterial. So bacterial, and can you mention quickly the bacterial if someone know? And the other association will be Currarino triad, yeah. So the most important association, bacterial and Currarino triad. You can see also the other association. Yeah, vertebral, anorectal, rhubarb, perfect, continue. Yeah, esophageal, Vertebral defects, ALAء, anal atresia, cardiac, tracheoesophageal fistula, renal limb abnormality. I agree with you. So this is vector. So the other association will be here. What is here? Can you describe it?
Scimitar sacrum.
Scimitar sacrum, yeah. Osseous defect in the right side, as you see here, the arrows. And in the CT, what happened? What do you see in the CT? You can see this is fluid field lesion.
Hypodense lesion.
Yeah, hypodense lesion. So maybe it is what is called curarinotyad. What's curarino? Sacral defect, deformity, and anorectal malformation. Yeah, perfect. And
Presacral mass. With the
yeah,
presacral mass.
presacral lesion as here. Either teratoma, lipoma, dermoid. Okay. Reem, perfect. I see many new stars, plus Nirmeen and Marwa and Ala. Yeah, mashallah. So let's go another case. Frontal radiograph in the pediatric patient. How you describe it?
Right hemithoracic hyperlucency.
So the most common question to ask is like, is it the pathology right side or the left side?
Right side, it causes deviation of intestinal structure.
Okay. So right, I see that maybe some suggestion. Yeah, but yeah. So the right side of the pathology. Everyone agree now? So perfect, perfect, Abbas. So when you find right side hyperlucency, your first differential diagnosis in pediatric age group will be
Foreign body
foreign body.
inhalation.
Perfect. Yeah, foreign body inhalation. So foreign body inhalation, it will be the most important differential to put. Yeah. Then try to search for the foreign body if you can see it. Maybe if you make decubitus radiograph, maybe can be helpful. So what happened here when he make this decubitus radiograph with this patient, the same patient? Yeah, there is air trapping. And the right lung now proved to you to that the pathology in the right lung, right? Yeah. The most important that it is in the lower airway, the foreign body, and at the level of left main stem bronchus. Yeah. They like to show you some foreign bodies in general in pediatric. They like the foreign bodies, so be careful about it. Yeah. So here there is foreign body in the where? In the larynx.
Larynx.
In the larynx, yeah. In the subglottic region. And this one they like to mention in the MCQ again and in the short questions. How to differentiate between tracheal foreign body and the esophageal foreign body. So this one is esophageal foreign body, yes. And they make endoscopy and you can see that they remove the foreign body after it, yes. So again, Reem, yeah. Ala, perfect. I see that there is some answer about the question of how differentiate between esophageal and tracheal. So in phase in the esophagus, in profile in the larynx. It will be end on in the frontal as the trachea extend posteriorly. Okay, perfect. Let's show you something until I prepare for you something else. What do you think about this case? And again, is it the pathology in the right side or in the left side? So when you find that the left side, it look like the normal. Why? Because this is the normal vascular markings, and it should be that the lung markings reaching the end of the lung fields. Here you can describe it like hyperlucency again. Yeah. So when you find it, either it can be differential, unilateral or bilateral. Yeah. Your first, you will see, is it unilateral or bilateral? So it's unilateral like this. It's much easier. If it can be technical, like rotational, as you mentioned, Nermeen, perfect. So first rotational, and then Boland, it will be very nice differential. Yeah, Boland syndrome. If it is absent pectoralis, it can be what we mentioned from while foreign body, macloid, the rabab, perfect. Marwa, mastectomy, perfect. Macloid, Swire gems, okay, the same. Hypoplesia. So it can be also pulmonary hypoplesia. Yeah. Like this one. It is not very nice picture, but yeah, it can be hypoplesia. And sometimes you know that the pulmonary hypoplesia, it is like there is some association with renal agenesis and autosomal recessive, yeah, polycystic kidneys. Okay. Anyway, can be macloid like this one, Swire gems, hyperlucent, Butter, Fauzi, okay. It can be also something like this appearance, or how we describe it.
Bronchial atresia.
Yeah, you can mention first that it is localized hyperlucency, right? Distal to the pathology. So this is the pathology, and now you can mention one sign, very nice sign if you saw it. So like
Finger and gloves.
fingering glove, perfect. So fingering glove, and they show you in the nuclear that there is absent uptake or absent tracer uptake. So you are talking about what's called bronchial atresia, which included in the localized hyperlucency, distal to the pathology. Perfect. And finally, when you find it like this one, and they show you this image without this image, so you are talking about
Congenital
Marwa,
lobar
perfect.
emphysema.
Yeah, congenital lobar emphysema. Yeah, congenital lobar emphysema. It can come to you as opacity first, then in serial image it ends with hyperlucency. Then the image, the end image will be, yeah. So congenital lobar emphysema, one of the good differential to put. So start with consolidation and end with lucency. Yes. Okay. And this one, the famous one, maybe I can show the X-ray first, then it is easier for you to make the differential. Yeah, CCAM or CBAM. Yes, Marwa, Justiana, Rabab. So the cystic appearance, cystic mass in pediatric, you are going to mention CCAM, congenital pulmonary airway malformation, which is hamartomatous proliferation of the terminal bronchioles. And you know that it can be many types. The most important differential, it will be the diaphragmatic hernia. So look in the continuation of the diaphragm, if there is any continuation or interruption of the diaphragm or not. There is many types and depend in the cystic appearance of these lesions. So focal lucency, it can be the CBAM, congenital lobar emphysema. At this case, yeah, or this case. So put in your differential diagnosis. Okay. Again, CBAM, and here is a bit hard to differentiate with the diaphragmatic appearance. Maybe the diaphragm is not very clear, but this one I think is easier now to mention that it will be zoom. Yeah, perfect, hernia. So this one, it will be the hernia one, what you like to see it. Okay. I want to show you two cases before we forget our PET-CT hybrid image, just to continue what we mentioned last time. Okay, so we'll try just to make some refreshment every time until you are used with this type of images. Try to describe when with this multi-finding we can put differential and reach final. Thank you, Dr. Fauzi. Yes? You start with multiple uptakes in the vertebrae. And do you think that just here, just uptake in the bone, or maybe there is some soft tissue as well? Do you think that maybe it's soft tissue? Yeah. I agree with you that there is some high uptake in the femur, in the bones, symphysis pubis. I forget to, if there is anyone who have experience about the exam, I forget last time to ask about who passed the EDIR, and congratulations again for the EDIR passers and any exam passers through the many last periods in the, we received many good news about the who passed the exams from many months, and this month again. So if you would like to share your experience, just take the mic and try to talk if you like. Okay, I'm waiting if someone want to share his experience. Okay, so don't forget the liver uptake. You remember the tricky case last time? It was the primary was liver. So the liver one, spine, the bladder is not easy, but you can see that this is physiological excretion of the FDG uptake. Yeah. So liver, bone. I see that everyone here, Nirmeen, Rabab, Marwa, all our stars today are going to mention the liver and bone. This is a 16 years old patient, still pediatric, and he present with weight loss and pain. He even did MRI, FDG, PET-CT for staging, and they find this left iliac fossa mass with soft tissue, as we mentioned. Yeah, and they find that Yeah, it can be metastasis. Now time to mention the differentiation. It can be metastasis, then your tricky, it will be what is the primary? Okay. It can be the primary, the bone, then you will think what it could be. If you mention the sacrum as a primary mass, what it could be. Yeah, it can, but I will ask you a question. Do you think that chordoma can metastasize like this? Do you see it like a regular, typical? It's not typical, right? You agree? Marwa, good differential. Ewing. So what is called, Rida, you can talk, just you can talk. If anyone want to talk, is free. We are in free session, so just it's radiology talks. Anyone want to talk, he can take the mic. So not typical, yeah. It's just locally aggressive, so not typical to metastasize. Ewing and all round cell tumors, it will be good differential. Yeah, I'm trying to wait. The always, I don't know why always you forget to mention differential, which is very common. Like it can involve anything. I always wait from you to mention it in every session as a first. Yeah, Reem, thank you. So all Marwa and Yermia. Now yeah, leukemia and lymphoma always with you in your bucket. Lymphoma, leukemia, metastasis in your bucket always. Yes, this one have something which is good entity to know, something called post-transplant lymphoproliferative disorder or lymphoproliferative disease, which is good entity to know. And lymphoma is very common. Is like, yeah, can be with this. Okay, nice case. Just to know, they have very good article about lymphoproliferative disorder in the radiographics. You can just search for it and read it. Very nice. Okay. Then I will show you this case, and we have still time. Okay, we have still time to go to the convention again. Okay, what do you think about this? How to describe? 16 years old patient, female. They have already primary, and they make a staging. Try to describe. I think the most helpful here will be the MIP. Do you remember when we talk about the diffuse uptake? When you find this diffuse uptake in the bone marrow, we mentioned, ask about treatment, right? It can be hyperplasia, yeah, and it can be bone involvement, yeah. So ask about chemotherapy, can be hyperplasia, yes. So forget it now. What do you see else? Nice differential. So with this lymph nodes, yeah, you will think about maybe lymphoma as a good differential. And also I want to, yeah, there's pleural effusion. Do you agree? And there is low grade uptake in this. Yeah, the bone diffuse uptake. So no focal uptake, is all diffuse uptake. But there is some lymphadenopathy. So lymphoma is good differential. What else? Nirmin, we are talking about pediatric age group, so take care, revise. So lymphoma and leukemia is okay. Yeah, you think about many things. Yeah. Neuroblastoma, do you agree? But is not in this age, right? Okay, so take care. Multiple myeloma, neuroblastoma, it will not be in this age. This patient is like 16 years old. Okay, so this one is not easy to get, but just to know that this patient have what is called alveolar rhabdomyosarcoma, and there is cord compression. and that's why they request for him FDG PET-CT. So it can be lymphoma, leukemia, and it can be something very rare like sarcoma, one type of sarcomas. Okay. Okay. I will ask you just one question about this. This is another case. So, what is the difference between this one and this one? What happened? Nirmin, revise again. It's okay. So what happened in this patient? What do you think about the change happened here? What is the difference? Try to pick up difference. The bladder uptake is the same and it is physiological. The ureteral uptake and the renal uptake through the pelvis is physiological. So don't look about it. Maybe some bone uptake. Okay. Okay. Yeah, where is in the vertebra? And he show you the CT. So can you localize where exactly in the vertebra? Is it in the vertebra or it is outside? No, the heart is, it can be like this. No, it is not. And salivary gland as well. No, it's not. Sorry, the Valdyer's ring. So no. So do you agree that the pathology is here? So what is newly developed here? After 4 months, there is no new soft tissue. Yeah. So where is the position here? Where is it? This one? Paravertebral. Perfect. So retrocrural or paravertebral soft tissue. This patient already received the chemotherapy and resection of liposarcoma, but there is residual lesion, and it gave this newly developed lesion, which is this one. After 4 months of treatment, he developed this one. So this means that this patient have disease progression. You can read now the story. So the most important to make the follow-up and see the previous and the changes, what happened. Okay. We have less than, I think, 6 minutes. Okay, we can just go few cases from the pediatric, then we finish our session for today. I hope that you enjoy it. Okay, so can you describe it here from this? You will put it like anterior mediastinum, middle mediastinum, posterior mediastinum, or not mediastinum at all? So do you remember the rule when we talk about the differentiation between mediastinum or the pulmonary? So do you agree that it is going more to be pulmonary or going more to be mediastinum? So if you mention that it is mediastinum, try to figure out the angle with the mediastinum border. Yes. And yeah, so this is what is called, to just to go quickly, this is bronchogenic cyst. Yeah, bronchogenic cyst. So as you mentioned, it is if it is mediastinum, there is no obscuration of the cardiac silhouette. Okay, so it is intrapulmonary bronchogenic cyst. Perfect. Okay, this one we showed you before. Okay, we can mention it quickly. Yeah, what do you see here? Yeah, this is IVB, and yeah, you think that maybe this displaced callus is down. Yeah, so either water lily sign if you suspect that it's double moiety, but this one is not. And why is not? Because the other one, you see the pathology is here, and will be different in appearance. You have something here that give you the clue. What is the clue here? Marwa, perfect. What is the clue? So look in the image and tell me what is the clue here. Yes, suprarenal calcification. Suprarenal calcification with mass effect equal to suprarenal calcifications with mass effect equal to
Neuroblastoma.
perfect. So neuroblastoma. So when you find spine or pediatric age group immature skeleton and you find suprarenal calcifications with mass effect, this is going to be neuroblastoma, the most important. And then when you do ultrasound, is much easy now to mention that it is neuroblastoma, and you can find that the kidney and the appearance of adrenal, how it look. Okay, and in the MRI is much easier, as we mentioned before, we talk about it. Okay, so don't forget neuroblastoma. And when you check the bones, you are going to check the metastatic appearance of the bones. Okay, again, don't go, no osteosarcoma here. Don't put your differential. This age group, the important to know that the age group is very important when you put differential. So here will be metastasis, leukemia, and lymphoma, your differential. So this one, metastatic neuroblastoma, as we know already the pathology, but because I see that the age is very important. Okay, neuroblastoma, third pediatric malignancy after leukemia and CNS. It's aggressive tumor. The metastasis to the bone and the liver. Okay, it can be from the adrenal, from the sympathetic chain, it can be extra adrenal as well. Catecholamine, if it is less than 1 year, we mentioned all this already, right? Neuroblastoma metastasis, search for it. And it like what? How we describe this metastasis?
Suture diastasis.
Yeah, so it go to the suture. So it's like the widening of the sutures. So metastasis to the suture in skull of pediatric patient equal to suture metastasis or suture mass in skull of pediatric equal to what? The first differential will put, it will be neuroblastoma. Then you can put other differentials. Yes, so don't forget, neuroblastoma is very tricky in pediatric age. Put it always before leukemia and lymphoma, then put other differential. If we have time, we can just take this one. No, we don't have time, so less than 1 minute. So I would like to thank you, and I hope everyone enjoying. Next time, inshallah. And please, if anyone from the EDIR bus, we can just send the experience in the group, and any suggestion, anything we can add. Inshallah, next Wednesday. And we always try to focus in the exam side or point of view, and either for EDR or if more advanced, it can be for the FRCR. So we stopped in this one last time, and we can make some revision until our participant join. So if you have a single bubble or double bubble, as you know, yes, it will be the bob is perfect. So single bubble, it will be like atresia, either in the level of gastric, antral, or bilural. Yes. Then you are suspecting in another term, high intestinal obstruction, high OO, or maybe something more like in the GI, in the gastric region. Okay. So it can be single bubble or single bubble with distal gas, right? So single bubble, just as you mentioned, it can be as above, yes, dilated stomach, it can be gastric antral atresia. Giustiana, I think the most good modality, if you want to show you ships, gastric hypertrophic biliary stenosis, it will be the ultrasound, because it always come in neonates, right? So this one, he will show you when it is either gastric antral or biliaric atresia, or the other differential, what it will be. If you find any leucine distal gas, what you will think about? Iman, yes, what? Revise, Justiana, our stars today. We are missing some stars, but okay, let's try to think. So let's try to revise again. Single bubble, it will be gastric, antral, or biliaric atresia. Double bubble, it will be duodenal atresia. Okay. Triple bubble, it will be jejunal, yes, atresia. Yeah, Marwa, good evening. Okay. And let's go more further. If it is single bubble with distal gas, then now you should add another differential, especially if you suspect like a high intestinal obstruction. So what makes this appearance happen? Imagine that if the intestine in this area, it will have like something like malrotation or malfixation. And then
volvulus.
Perfect, yes. So the differential diagnosis would be perfect. So search for any faint leucency. If you find it, so now the differential will be emergency. It will not be just atresia, it will be emergency. Why? Because it will be the differential of mid-gut volvulus, right? Mid-gut volvulus, which is a surgical emergency. So your next step will be
barium meal.
Contrast study.
Contrast.
Yeah, and the next step of management will be upper GI.
Surgical referral.
Yeah,
Upper GI.
Yeah, perfect. Yeah. So this is what is called gut volvulus, and I can show you like if I show you the barium, like this, the upper GI study, then you can try to describe what's happening here. Then probably your first term here, you will mention what you will mention here.
Duodenojejunal junction on right side, and it's like a corkscrew.
Yeah.
Corkscrew.
More important to mention that in the right side and corkscrew side. Yeah. Perfect. So in the right side, because you should see this one here. Okay.
And there is no contrast past distally, so it is malrotation with mid-gut volvulus.
Perfect. Yeah. So there is dilatation of the first and second portions, and there is malrotation, and also some corkscrew sign. I agree. Sarah, welcome, Sarah. Okay, nice, perfect. So mid-gut volvulus, one of the emergency that you should know about it. And probably sometimes some examiner like to show you this sign as well. If you are lucky in the ultrasound, Then
whirlpool sign of
yeah.
midgut pulpulus.
Whirlpool sign, and it is like the rotation between the superior iman perfect, yeah, superior mesenteric vein and superior mesenteric artery. So what is happening here, that there is rotation, yeah, there is abnormal orientation between the superior mesenteric artery and superior mesenteric vein. Okay, so this is the most common three appearance that they can show you in the exam: either single bubble with some distal faint gas, or it can show you the corkscrew sign with the duodenum and the jejunodudinal flexure in the right side, and finally the corkscrew sign, the whirlpool sign, which is the reversal between the superior mesenteric artery and superior mesenteric vein. Okay. The differential diagnosis, as you know, what it will be if it is midgut volvulus, if it is not midgut volvulus. Nirmin, welcome. Okay, it can be, yeah, or something called lead spans. It can be the cause of this appearance sometimes. Perfect. Okay. And the main presentation clinically, this patient will come with bilious vomiting or non-bilious vomiting. Do you expect with this patient, this is MCQ, he will come to you.
The obstruction distal to ampulla of water, so it is bilious vomiting.
Perfect. So you expect that you will see that in the MCQ, it will be bilious. So this will be bilious vomiting and the surgical emergency. Yes. Okay. So maybe just move, and I think here, yeah, if it is lead band, we can just, okay, let's go to this case, show you this appearance. Differential diagnosis. If I told you this patient, this young patient, a pediatric patient, have trauma, so what is your first differential?
Duodenal hematoma.
Yeah, intramural duodenal hematoma. If I show you this appearance with dilated third portion of duodenum, then you are going to mention duodenal hematoma. Don't forget that it will be one of the non-accidental injuries. Yes, okay. Everyone agree? Okay. Let's go to another case, which is one spotting or Aunt-Minnie case.
Kids.
Rickets, perfect. And how you describe this appearance?
Distal cupping and fraying.
Yeah.
In addition, with diffuse osteopenia of the bone.
Yes. So cupping and fraying of the metaphyseal portion of the bone, so metaphyseal region mainly. And sometimes they show you this appearance to know that
bowing of the bone.
Yeah, and they will ask you which type of stage are you talking about? Is it healing or healed or active rickets? So you should mention one of the three, either active or healing or healed. So this one is should like be, do you think that is active or healing with this fraying and cupping?
Active ricket.
Active
Yes.
ricket.
So you should mention that it is not just ricket, you should mention that it is active rickets. And the questions here, they ask in the MCQ about the causes, especially the abnormality in vitamin D, and the other type, which is vitamin D resistant. Yeah. So they like much questions about the rickets. Okay, I think everyone know about. Just I can show you sometimes it can come to you at this one. Then maybe you can mention that with this bowing appearance, then if this patient is like a bit in the pediatric age group, but he is more older, then think about something not maybe related to rickets as a first
F1.
yeah, like something from the causes we mentioned. So it can be from something like what is called
Osteogenesis imperfecta.
renal osteodystrophy. Like if this patient have chronic renal failure, then it is not linked to just vitamin D deficiency. It will be linked to other types. Sometimes also they like to show you the rickety rosary beads, yes, or rickety rosary, and this one. Okay, let's go to another one. What do you think about this case? We have similar one last session.
Congenital lobar emphysema.
Yeah, when you find it in the left side, in the left upper mainly, and with this hyperinflation, yeah, then it is easier when they show you the CT. So this is what is called congenital lobar emphysema. So they think that it is like bronchial obstruction, and bronchial obstruction and something like closed the bronchus and some air trapping habit. The most common location, the left upper lobe. And you can memorize that the left lower lobe is for sequestration, the left upper lobe for congenital lobar emphysema. Okay? Okay. This is a common question in the exam as a differential diagnosis. So how you describe it first?
Lucent transverse
lines.
Okay, so lucent metaphyseal.
Lucent transverse.
Yeah, metaphyseal. You should mention the region, so metaphyseal bands. Then the question will be the differential diagnosis of lucent metaphyseal. And I see that many, like Sarah and many of you, mention leukemia at first. Yeah. So lining L, leukemia, I, it will be like maybe something illness, systemic illness like scurvy or rickets. N will be in pediatric, don't forget tumor. What is tumor in pediatric?
Neuroblastoma tumor.
Neuroblastoma. Perfect. MITS, yeah. MITS of neuroblastoma. And I, again, it will be for infection. Like what? What infection you would like to mention here?
Osteomyelitis.
It can be, or syphilis, which is not very common, is rare, but they like to mention it. SS, scurvy, and syphilis. When you find this metaphyseal, it can be normal variant or growth lines. Okay. So yeah, again, they like to show you this thing. So this one, if I told you that this patient had primary, what it would be?
Poisoning. Opposite. Echogenic transverse bands, metaphyseal bands. Increased density of metaphyseal bands.
Yeah, I agree with you that there is increased density. Yes, perfect. But what about the metaphyseal region itself? What do you think about
Erlenmeyer deformity?
Yeah, then you can think about that there is some irregularities between lucency and, like you can say that this area is heterogeneous, right, in the density between lucency and, so then what is your differential?
Abnormal.
Yeah, if I told you again that this patient had primary, so what it could be?
Leukemia.
Perfect. But leukemia, it will be infiltration. But I told you that this patient had primary, what it will be?
Maybe be neuroblastoma?
Yes, it will be neuroblastoma metastasis. Perfect. So it can show you everything. Okay, agree? I wanted to. And if I told you this patient have the very rare congenital disease, what is this sign called?
Weinberger sign, syphilis.
Yes, this is syphilis, Weinberger sign. Perfect. So this one is what's called Weinberger sign. And again, the syphilis could be included as congenital syphilis, could be included as differential. Okay. Nice. So let's go to this one, which is the lovely one. We show you something.
Is eosinophilic granuloma?
Yeah, eosinophilic granuloma, and you can see this appearance of lytic, but then sure that you will put differential of lytic metastasis or anything, but they mentioned that this lytic appearance have something like with the ages,
beveled edge. Beveled edge.
Yes. So when you find beveled edge in pediatric patient skull with this appearance, you are talking, yeah, sharp edges. We are talking about Langerhans cell histocytosis, and then
vertebra plana.
Okay, they like to show you the other manifestation of Langerhans or eosinophilic granuloma with vertebra plana. The differential will be if just this
metastasis,
leukemia, lymphoma, metastasis. Yeah, and the infection. Don't forget infection. Yes.
Lymphoma, trauma.
TB. Rihan. Perfect.
Trauma.
Yeah, it can be TB. This is not pediatric patient. I think this not to be included in this. So skip it. And finally, they like to show you again in the bone that yeah, it have eosinophilic granuloma. So
Eosinophilic granuloma.
Perfect. Don't forget that they like this vertebra plana differential diagnosis. You already mentioned it: leukemia, lymphoma, METS, infection, steroids, and maybe hemangioma. About the vascular compression, when you find anterior esophageal indentation, so it is
pulmonary sling.
Yeah, it is pulmonary sling. So this is like the MCQ question in the exam, and also they like it in the short about the indentation. Is it anterior, lateral, posterior? But when you find this anterior, so it is almost pulmonary sling. It is the most of differential diagnosis. Do you agree? So the left pulmonary artery will arise from the right. The left pulmonary artery will arise from the right instead of what? Instead of the main. So when you find the left pulmonary artery and it's like it comes in front of the esophagus, then this is what is called left pulmonary sling. Yes. Okay. You agree? Okay. Let's shift to another one. So let's go to our bubbles. Try to find which bubble they are talking about.
Double bubble.
Double bubble, which is like, yeah, I see Janan. Welcome, Janan, new star. Yeah, Iman also. Yeah, we have many. Shayma, welcome. So we have what is called duodenal atresia. Yes, duodenal atresia. What they like to show you here in this heart, why they show you this heart?
ممكن يكون العيان داون وعنده endocardial Cushing defect.
Okay, this is association with down. So if it is down, what it will be?
BSD.
endocardial Cushing defect ممكن.
Maybe, yeah, congenital heart disease, whatever. Okay, and it can be this
appearance.
So the most important endocardial Cushing defect. Perfect. So this what is appearance. So when you find duodenal atresia, the association will be in 30%.
Vater. Also vater associated with the duodenal atresia.
Yeah, okay, I agree with you. So most in region of ampulla of vater, right? Do you mean this?
Yes.
Perfect, yes, okay. So double bubble sign, we are talking about duodenal atresia. and you can confirm this with upper GI. Differential diagnosis again will be malrotation with mid-gut volvulus if you expect that this is like a single bubble, and it can be duodenal stenosis, duodenal
Annular
web,
pancreas.
and one we mentioned before is called variant is called
Annular
Annular
pancreas.
pancreas.
annular pancreas, perfect, and maybe some bands, peritoneal bands. Okay, nice. Sometimes they like, maybe you can skip this. Yeah, okay. Let's take this one, which is in the neuro, in pediatric age group. Then you find supracellular mass. So what is the differential
Hyperintense.
here?
Hyperintense on T1. Either hemorrhage or fat.
Craniopharyngioma.
Yes, so it will be with this cystic appearance and the high T1 signal. I agree with you, especially if I show you the CT. Then with this calcification, then you can going to either, yeah, then it will be craniopharyngioma. So they like to ask you about some pathological types. Either it is adamantomate
It is adamantinoma in 90% and papillary in 10%.
So the papillary type come in the old age, right?
The papillary type come in young age, always solid and supracellular mass. The adamantinoma is bipolar. The age is يعني in pediatric age group and old age, and almost always calcified.
Perfect. So let's talk about that. The 90% cystic, 90, as you mentioned, calcification, 90 enhanced. So like rule of 90, right? And they have two types, adamantomatous type and the papillary type, right? But if I remember, the papillary come in baba, like in a bit old age, right? Okay. So craniopharyngioma, yes. Let's shift this one. Yeah, we mentioned it already, so I will just skip it. Yes. Okay, so this one is much easier. Maybe I can show you this appearance first. So what is the abnormality here?
There is the soft tissue mass in the abdomen, compressing the bowel to the left side. Could
So
be
you think that maybe
paraganglioma.
abnormality here, right? In this side.
يعني neuroblastoma or
So let's go step by step. We mentioned that it will be obstruction, right? You want to mention that there is some dilatation and there is some obstruction. Yes, Rehan, I agree with you. But let's go in approach of high obstruction or low obstruction. So if it is low obstruction, right, or high obstruction first. If it is high, you are talking about mid-gut volvulus, duodenal atresia, duodenal web, annular or jejunal atresia also. If you are talking about low atresia, low bowel obstruction, so yeah, so
Ileal atresia.
Yeah, you are talking about can be low. Then you will mention your differential. Then if I show you, you are going to do enema, right? We are going to do contrast enema, right? Contrast barium enema. Then
oil spring sign.
Yes, exactly.
Of intussusception.
Yeah. So don't forget intussusception as one of the most common differential that can happen. Okay. and if they show you the contrast enema, it will be much easier to know at the level of obstruction. And let's have a look in this one also. Yeah. So they like us to ask you about this, which is not many people do it now, but maybe. So what they do here after they find the intussusception?
Pneumonitic reduction.
Hydrostatic dilatation.
Is it hydrostatic or pneumonic? It is air enema or saline enema? What do you think?
Air
Pneumonic.
Air enema. So sometimes
Pneumonic enema.
Yes. So this is what is called air. Yeah, Rihan, Shayma, close sign. Okay. Shayma, Muhammad. Thank you, Shayma. Rihan. Okay. Okay. Iman. So we are talking about successful air reduction or unsuccessful air reduction. What do you think? So it was here.
Successful.
Perfect. And after he make the air reduction, it is have good success, right? With complete passage of the gas. So we are talking about, they like to ask you about this in the exam, about the, either if the, it is not common now that the radiologists do it, but yeah, they still asking about it. Okay. Let's go to this one.
ده stable sign بتاع الكروب.
It can be stable sign, especially if this
hemangioma.
present with stridor, right? And it can be
Hemangioma, asymmetrical.
If it is asymmetrical, it can be hemangioma. What else is the differential? It can be what? So hemangioma, okay. So let's try to say that this is the trachea air shadow. So and you find some indentation. So you expect to find like tracheal narrowing or tracheal mass. Sarah, polio? Maybe you can mention tracheal granuloma, right? You mean if there is granuloma or infection here, then it can make this. It can be papillomatosis.
Steeple sign. This is a steeple sign.
A steeple sign, you mean croup, right?
Croup.
Yeah.
Yes.
Yeah, if it is like symmetrical and more sharp, maybe yes. I agree with you.
Okay.
But let's talk about if this is like one side or unilateral tracheal narrowing. So you are talking about maybe foreign body as well, maybe mass, maybe infection.
General compression.
Yeah, so this is what's called differential diagnosis of focal tracheal mass or narrowing, okay? One of the most common to be can be hemangioma, especially if I show you this picture in pediatric patients. So then if you mention hemangioma, they like to ask you about something like syndrome or something. Do you remember any of them in hemangioma?
Osler Weber?
Are you sure? Do you remember any thing come in the with hemangioma? So just I want to show you something very quickly because now it's more easier to know. So when you find this one, so this is a difference between hemangioma and, you see, the croup, okay? So the croup here is easy to can see the steeple sign, but when it's asymmetrical in one side, then it is more to be like a mass infection and so on, okay? Is it easy now? Is it easy? Okay, so the
Yes.
syndrome. Okay, what I want to show you, this syndrome, I want to show you quickly. This is what's called FACES. They like it in the exam. It is associated with subglottic hemangioma, eye abnormality, coarctation of aorta, arterial anomalies, hemangiomas, posterior fossa, dandibucum. That's what's called FACES. It can be association 7%. Okay? Is okay with you? Fine? So this is what is called subglottic hemangioma. Before we leave it, this area, let's just revise 4 patterns of, if you get the lateral, because this is also important in the exam. So I will show you and we can try to figure out which one. So this one, what is this sign called?
Thumb sign.
Thumb sign.
Thumb sign. So you can put your finger here. So it is thumb sign. And denote that the patient have epiglottitis. Perfect. So this epiglottitis. And here, what is happening? What do you look for in the checklist of pediatric lateral?
Retropharyngeal abscess.
Yes, retropharyngeal abscess. Perfect. And here, the most common you look for the
adenoid.
So the lateral for adenoid, yeah. So the most common that you see it's adenoid, and there is something which is called also oxidative tracheitis.
Tracheitis.
Perfect, nice. So just to go back to our presentation. Okay. Again, if I mention the okay, let's
dense metaphyseal bands.
Perfect, yeah. If we mention the lucent metaphyseal lines, they like to show you the lucent. So this is the dense metaphyseal bands. So now they'll ask you what is your differential, top differential.
Lead poisoning.
Yeah, they like to start with lead poisoning, heavy metal poisoning.
Vitamin D.
Yeah, and the one of things that you like to mention that it's involving even the fibula.
Treatment of leukemia.
Treated
rickets.
And it can be treated, yes.
Neuroblastoma metastasis.
Is not common because we mentioned it like the neuroblastoma, it's more with lucent, but yeah, it can be. But with lucent appearance more, it's permeative lesions like we show you in the previous one. Okay, you want to see it again or it's fine? Okay, like this is the metaphyseal lucency, so it's a bit different from the metaphyseal density or high density. Okay, you can see it. Okay, so treated rickets or healing rickets. Again, SS, scurvy, Sarah, perfect. And please, Rabab, what you want? Okay, yeah. Leukemia, normal variant, and hypothyroidism, right? So this is what is the dense metaphyseal bands. You can check them, okay? Let's shift to this one. Sometimes the pathology, it can be the dilatation or the gaseous distension. Sometimes it can be the absence of gases, right? Do you agree with this?
Spina bifida.
So I agree that there is something here as a normal variant. But where is the absence of gases here?
Right side of the abdomen.
Yeah, so right side of the abdomen. So what do you think in pediatric patient that it can be?
Mass lesion compressing
neuroblastoma.
the bowel to the left side, neuroblastoma, Wilms tumor, hepatic origin neoplasm.
Hydronephrosis.
Yeah, nice. Good differential. Then
associated with the skeletal abnormality.
What? Sorry.
Neuroblastoma associated with the skeletal abnormality.
Maybe. Nice. What else?
But with the spine bifida or a defect in the anterior spine, I put anterior meningocele.
Good idea. Very nice idea. Nermin? Marwa or Nermin? Both are stars, but okay. Nice suggestion.
Marwa.
Marwa, okay, thank you. Yes, good suggestion. Okay, now, okay, I agree with you all, but don't forget one thing, that if I told you that this patient had primary, but this patient had primary and he take treatment. So let's think about something else. And they like to mention that this is the preferred location of this appearance. So this is very very important question in the exam to mention. If this patient have primary and he received the treatment, and this treatment like a chemotherapy, for example, what it could be?
Leukemia.
Yes, perfect. Perfect. 10 stars. So if I show you this one, it will be easy. So it looked like appendicitis, but in pediatric age group with very much stranding, and maybe you can find like some collection. So what is of typhlitis? Where is it? It can
Cecum and descending colon.
Yes, the cecum and the cecum and descending colon and the terminal. So neutropenic colitis, right? So this is what's called typhlitis. It can happen with leukemia or lymphoma or organ transplantation. They like to mention that it is like a mass, maybe in the X-ray with thickening, and the CT, as you see, there is thickening in the cecum with pericolic, and the differential will be appendicitis. And the good thing that to mention that you shouldn't do what is called what? You shouldn't do what?
Barium enema.
Barium enema. Yeah. Why? Why?
For perforation.
Yeah, you have risk that it can be, it can have perforation. Yes. Just I want to show you this. Marwa shared with us something interesting, so let's take it and share with you. Just the differential between the papillary type and the adamantomatous type in craniopharyngium. So you can remember that the BAP from Baba, it comes from the adult type, right? As we mentioned. And the adamantomatous type, which is the 90%, will be cystic appearance, okay? And they have much differential, but at least you can check the MRI and see that the supracellular and cellular, and again cystic appearance. And the papillary type, which come in the adult one, is almost like a solid mass. Okay, so you expect when you find like a cystic appearance to go with adamantomatous type, and this happen in the age group pediatric, and also it can be bimodal. But the papillary type is most exclusive in adult type. Okay. Do you agree? Okay, so I just will close this one and go back to our presentation. Okay. When you see like ugly mass in the head and the neck, big ugly mass, what is your differential?
Cystic hygroma.
Yes, perfect. It can be cystic hygroma. It can be what, Marwa? Yes, perfect, Sarah.
Lymphatic malformation.
Yeah, it can be like a vascular or lymphatic vascular malformation. So this is the big ugly lesion. It's look like dilated lymphatic spaces. All with the cystic hygroma, it like in one side, it's asymmetrical one. Maybe sometimes it can involve everything, but it's very, when you find this big ugly, it's more to be lymphatic. Yes, okay. Your differential, just to check. Yeah, and they like to show you in the MRI, the most important to mention that it have what?
cyst with fluid level insinuate between the tissues.
Yeah, very bright T2 signal. Yeah, you want to see to mention that the most important when describe it in the reporting even that it is very high T2, very high in the T2. The differential diagnosis will be abscess, it can be stroma, it can be branchial cleft cyst. Sorry, is the cystic hygroma the same? It can be branchial cleft cyst, a thyroglossal cyst, but it is more midline and smaller than this one. It can be necrotic tumor. Okay. So yeah, Rihan, good to think that you mentioned it's not respect the spaces, so it can involve all the spaces, right? So did I confuse about? I think the cystic hygroma is the same like lymphatic malformation, right? Or I'm mistaken in this because
same as lymphangioma.
So cystic hygroma is lymphangioma just, but the lymphatic malformation is like a big term. Yes, I think
yeah,
the
lymphatic malformation
may be the same meaning, right?
Yeah,
And
of course. Yeah.
I think I am confused. Just for 1 minute I think about something else, so I get confused. So let's just shift to this case. Yeah, the same. Yeah, I want to mention that it is the same. Yeah. Okay. So what is here? Your differential or top differential?
Second brachial cleft cyst.
Yeah, this location anterior to the steromastoid tumor. This is like the second branchial cleft cyst. Yeah, and your differential will be again lymph node, necrotic
lymph node.
Perfect. Nice, Mark. You catch me. Again, if they show you this appearance, this is fistule, and in the ultrasound, when you find like something cystic, you are talking about lymphatic malformation. It can happen everywhere. Okay, let's shift to another case. I will just respond to one message in 1 minute.
Crohn's, cobblestone.
The Crohn's مع skip lesions.
Yes, I think is cobblestone. I think Crohn's, one of the good differential to mention. Cobblestone, especially when he concentrate in the terminal ileum. So
lymphoma.
About yeah, it can be cobblestone of Crohn's. Yeah, and maybe what do you think about this? Is it sign? Yeah, Joanna,
string sign?
String sign of contour.
New star. Yeah, string sign. Okay, thank you, Joanna. Thank you, Dr. Ahmed. Okay. Yes. So they like to mention that when it is involved this the fibrofatty proliferation. They like this description in the pathology. They like to mention that it can be like fibrofatty inflammation, right? And
on CT.
Yeah, in CT, exactly. Then if they show you something like this,
fistula, perianal fistula.
Yeah, perianal fistula and abscess as well. You can see the gas inside the collection, so it is abscess with branding.
It's horseshoe type, horseshoe fistula with abscess.
It is horseshoe. Yeah, okay, I agree. They like to ask you about something in the Crohn's, especially if you show you the MRI to know is it active Crohn's or not. And from the CT or the barium, they like to ask you about what? about the skip lesions that you should trace and find another lesion if there is any skip lesions. Okay. In the CT, they will show you either the abscess, sinus fistula, or something called creeping fat. Okay. Okay. Let's just shift to this one, which in neuro.
Aqueductal stenosis.
Why?
Hydrocephalus causing hydrocephalus.
Suprasellar arachnoid cyst.
Supratentorial.
Yes, it is a third aqueductal stenosis, but you should mention that the level, where is the level? Yes, to give you the key. So the third ventricle, do you see the floor of the third ventricle and the appearance of this bowing appearance? So this means that there is hydrocephalus, as you mentioned, and
Normal for ventricle.
yeah. So
Supratentorial hydrocephalic changes.
yeah, supratentorial hydrocephalic changes. I agree with you, and it can be either congenital or acquired. Then okay, I will just show you this one. So the level of narrowing will be at level of midbrain, right? You can say that it will be in the intercollicular or collicular level, right? Yeah. If it is acquired, it can be like infection, like meningitis. Okay. So the dilatation will be at level of lateral and third ventricle. So lateral and third ventricle. Then you can see that the fourth ventricle is almost nice with not dilated. It can be seen maybe like here, and it cannot be seen sometimes. The most important to check, especially in this patient.
ليه ما قلتش suprasellar arachnoid cyst؟
From one image, I agree that it will be difficult, but if you see this bowing, this means that there is not just cyst. It should be like dilatation of the lateral ventricle and dilatation of the third ventricle. So
اصل مش شايف التانلنج او الفانلنج بتاع الاكويدكت.
It can be. I agree. From one picture, it cannot be like specific for it.
Okay.
Just to mention that the tectum, you should check for the tectum if there is any
Tumor like tectal glioma.
Yes, perfect. So maybe aqueductal stenosis, maybe tectal glioma as well. Okay. And I agree with you. From one picture, always is not just you give the differential and you scroll the image if you have the. But I mean, what is common? Like if you show you pediatric patient in the exam, and you have dilatation of lateral and third ventricle. So the most common it would be aqueductal stenosis. Okay. Then go further if you need, if they ask you more and more. Okay. Yes. What? Try to activate your checklist. Right cardiac border hazy, maybe. So what? What do you suspect? Nice, perfect. So do you agree that this is like triangular opacity here? Yeah. So give me differential. Activate your differential list. Sure that your next that you will check the previous image. If they have, then it can be fat bed, maybe, but it looked like more than fat bed, because you can see the diaphragm here, and it lost in this area and also here. So
Sequestrated lung segment.
it can be hernia, maybe. I agree. Maybe hernia. What else? Cyst. Nice. So if I show you Marwa, yeah, perfect, Sarah. If I show you this one, what it will be?
Sequestration.
Sequestration. Then
Sequestrated lung segment.
Yeah, either intra or extra. So if he is adult, most commonly it will be like sequestration. Which type?
Extra.
Yeah.
Extra in adults.
Yeah, and they like to ask you in the intra adult, it will be intra. Yeah, Justiana, Karim, Rihan, it will be intra. And they are like to ask you about the most important difference between the intra or extra types of bronchopulmonary sequestration. This table, you remember this table in the textbook? Yeah, tell me. The drainage?
Intrapulmonary venous draining to pulmonary vein.
Yeah.
While extra to systemic.
Yes. So the drainage of either the drainage of the intra or extra. So the drainage of the intrapleural, it will be through the pulmonary, but the extra one, it will be. So which one have more congenital anomalies? Extra one. Perfect, Justiana.
Yeah.
Which one have its own pleural covering?
Extra.
Extra. So if you expect like an adult patient and you have this one which look like infection, and he asks you about something you put in congenital, it will be sequestration, because it have something called recurrent infection. Perfect. Okay. And maybe he can show you something like this, and then you want to show you the arterial supply, or maybe, yeah, you can see it easy here, right? So it can be again pulmonary sequestration, some cases of this, or they can show you the drainage, or you can see the supply here again. So an adult patient will be almost intra type. Yes. Okay. Again and again, one of the most common type important question in the exam, it will be this one, which is
bronchomegaly, Munir Khan.
Munir Khan disease.
It can be, but the common is common. So
The bronchiectasis is upper loop.
Joanna, perfect, Joanna. So start with the most common. The most common to be cystic fibrosis.
Cystic fibrosis most common.
Yeah. So if he show you this appearance with tram track appearance, most common in the upper loops. Sometimes they have like good clue. If sometimes they show you this one, but after treatment. So what do you expect to see if this patient have treatment? Cystic fibrosis. What do you expect to see? Like tube, line. What do you expect to see? If you want to add to this image like a tube or line, what you will add? Justiana, perfect. Portacath. So when you find portacath in young patient and you find something in the lung, equal in the exam to cystic fibrosis. Okay? So this is like a rule for you. If you find young patient and they have like upper lobar affection and it look like tram track lines and with portacath, or just if you find portacath and you find maybe subtle because maybe you have treatment so you will not find much changes, then you are talking about what is called cystic fibrosis. Then if he show you the pancreas with this appearance, that will be
pseudo-lipomatous hypertrophy.
Yes, pseudo-lipomatous hypertrophy or fatty changes of the pancreas, then it will be a piece of cake for you. Okay, cystic fibrosis. One of the big entity in the pediatric. Sometimes they like to show you something like this, not very common, but maybe to put a differential. So try to put differential then. Then the question will be, is it pulmonary? Is it pleural? Is it chest wall?
There is unilateral hemiopathification of thorax وفي overcrowding لل overlying ribs.
So what will you choose? You choose the pulmonary or pleural or chest wall. Yeah, Sarah, perfect, Sarah. So to be not pulmonary.
I think it is chest wall.
Perfect. So at least it will not be not pulmonary. So you are talking about either pleural or chest wall. So I agree with you that it will be chest wall. So where you find chest wall in pediatric patient, what is your differential now? Start like everything: congenital, traumatic, inflammatory, neoplastic, until you reach.
Ewing, Askin Bennett.
It can be tumor like Ewing sarcoma, yes. And
Askin Bennett.
Askin tumor, which is type of Bennett tumor. What is Bennett? Can you refer it? Bennett?
Primitive
neuroepidermal tumor.
Perfect, nice. So it can be chest wall tumor and with rib destruction. And as you mentioned, rib crowdedness, at least here, you can find something like soft tissue mass as well. So if it is not, we can just widen your differential. So this entity is Nermeen, perfect. Round cell tumor. This is what's called round cell tumor. Okay, I agree, Marwa. Pleuroblastoma, one of the good differential. What else? So can just show you the tumor, the list, then it's easy for you to memorize. Any sarcoma like osteosarcoma, chondrosarcoma as well can be. So Ewing and their sisters like osteosarcoma, chondrosarcoma, and don't forget always the metastasis. Yes. What do you differentiate? What do you see? How you describe it?
Subarachnoid hyperdensity.
Revise. You are in MRI, so check again the answer.
TB sarcoid.
Hyperintensity, back meningitis.
Yeah, so you want to mention that there is if this T1 post contrast. So you
TB is the leptomeningitis.
Yeah, so describe it as nodular meningeal thickening, or you can say meningeal enhancing thickening, maybe nodular, and it is almost basal, right? So basal meningitis, it can be infection like TB, it can be what else? Metastasis, do you agree? It can be leptomeningeal metastasis, or yes, it can be sarcoid, but it happens much in older age. So this patient,
basal suggested for TB.
Yeah, pediatric. Okay. So this is what's called the basilar meningitis, at least. Okay, go to this one, which is easy one.
Tubular sclerosis.
Yeah, you can mention that calcified subependymal nodules equal in differential diagnosis to tuberous, one of the big differential. And we mentioned
torch
already
infection.
in the neuro
Congenital torch.
Yes, torch infection. Oh, okay, I agree. HIV, toxoplasmosis, cytomegalovirus. So you can mention that it can be one of the calcification that you should put your differential diagnosis list. Okay, we mentioned in neuro details about it, but okay. Let's revise this one.
Anterior mediastinal mass.
Why, Nirmi, Marwa? You remember the lines when we talk about the lines? So what is happening here? The line and stripes.
Silhouetting.
Is easier here that you have the lateral. Yes. So what? Sorry?
Silhouetting the mediastinal structure, but it's clear on the lateral.
It's clear much in lateral. So there is widened in the superior okay? And you can see that the, you can see that the lines and stripes here also is silhouetted in the right and left side. So it's most mediastinal anterior or middle, but when you go to the lateral, so it is anterior. So yes, anterior mediastinal mass, then your differential will be 4T's, Rehan, perfect. So this is the 4T's. One of them will be the lymphoma. Okay. Okay, what about this? Try to describe what you see.
Achondroplasia.
Why?
Flat acetabulum, interpedicular distal distance narrowed distally.
Yes, the interpedicular distance. So if you try to draw the pedicles here, the distance is narrowed, nice, caudally. Yeah, and
tombstone, iliac bone, tombstone.
Tombstone, iliac bones, okay.
Champagne glass pelvis.
Champagne glass pelvis.
Flared metaphysis.
Okay, metaphysis. Okay. What else?
Sacral jutting.
Okay. I agree with you. What else about the acetabulum? Did anyone mention it? Because I.
No, flat acetabulum.
Yes, flat or horizontal acetabulum, perfect. And the upper femur like the ice cream scoops. Okay, so this criteria all about achondroplasia, just to revise it, easy. So which one, this one, you can consider this as with metaphyseal flaring, right? Bilateral here. And the bone affected is the femur. So this
short tubular bone, rhizomelic dwarfism.
Rhizomelic dwarfism. So this one is type of dwarfism, which is rhizomelic because involved the femur, right? Okay. Okay, what else? Okay. Inverted V configuration, right? Right. What else? I see chevron, sink, Joanna, yeah. Here, what do you see? I will describe it. Sarah? Okay, frontal bossing. And what else? Enlarged calvaria. Yeah. The skull base, shorten the skull base. Yeah, tell me.
D-shaped cella.
Maybe there is not much, but okay. What about the, before. What about the lumbar spine? What do you see in the lumbar spine? The look of
sickle cell anemia or thalassemia?
The same patient.
Anterior
Talking
peaking.
about achondroplasia, just to revise the criteria. So like a bullet, right? Bullet vertebra, Sarah. Perfect.
Bullet shaped.
Yeah. Okay. So this is what is called achondroplasia. Already revised all the criteria. The most important to do this is rhizomelic dwarfism. The interpedicular distance is one of the good clues to look. We already mentioned trident hand. So this is what's called trident hand. Okay. And flared bone metaphysis, we already mentioned it. Okay. And champagne glass, this is what you like to mention always. And yeah, okay. So dwarfism with horizontal acetabular roof, the first one, achondroplasia. There is something called thanatrophic or epiphyseal dysplasia. Okay. And when you find the anterior vertebral beaking, like we should maybe here, but it's not very clear, again, you will mention achondroplasia and the differential of this, what it will be.
Mucopolysaccharidosis.
Yeah, mucopolysaccharidosis. Perfect.
Achondroplasia.
Yeah.
Down syndrome.
Yeah, Down syndrome. Yeah. So this is what's called anterior vertebral beaking. Yes. Mucopolysaccharidosis. Morchio type is middle, MM, and the Hurler type is inferior beaking. Yes. This is one of this dysplasia. I think when you find, yeah, the bell-shaped thorax.
Bell-shaped thorax.
Perfect. Bell-shaped thorax, and maybe some pilatus spondyli.
Severe pilatus spondyli.
Perfect. And the lungs also is hypoinflated, right?
Hypoplastic lung.
Hypoplastic lung. So hypoplastic lung with bell-shaped, you are talking about
Thanatotrophic.
Yeah, thanatotrophic, yeah, dysplasia. Here also you can see the short ribs, making the sternum also hypoplastic.
It is thin ribs.
Yeah, short and hypoplastic ribs. Yeah. Okay, go to the skull. This is what is called, which is called this one.
Lacunar skull.
Sorry, what?
Lacunar skull. Looking a tri-loop, the clover leaf.
Clover leaf, perfect. Clover leaf skull, maybe, yes. So this all, or like, you know, that this patient have one of the dysplasia, which is rhizomelic also, or rhizomelic dwarfism, with severe pilatus spondyli and disc spaces.
It is lethal, one of the lethal skeletal dysplasia.
Yes, lethal. So it, yeah, mostly will. Yeah,
telephone shaped.
Yeah, telephone shaped or receiver femurs. Yeah, telephone shaped. Also, this all included in the. And what about the iliac bones? It is small.
Hypoplastic.
Yeah, hypoplastic. So this is the commonest type of thanatrophic. We already mentioned most of the criteria. And yeah, when you find the small bell shape, just to remember, thorax like this one. So your differential diagnosis will be Butter, as you mentioned, or maybe some abnormal muscles or bones. Yeah, will be Butter, abnormal muscle or nerve system abnormality. So you can make like this entities, either Butter, which have lung hypoplasia, maybe usually there is cause, yeah, and abnormal muscle or bones. And this one, they have this Jones syndrome, maybe. I don't know if you pronounce it well or not, but let's have a look how it can be. This one, which is asphyxiating, the one which is asphyxiating.
Genu syndrome. Genu syndrome.
Genu syndrome. Okay. So this one very rare, autosomal recessive osteochondrodysplasia, and you can include it when you find bell-shaped thorax. Okay. Okay, just to make up this. What is your differential?
Rhabdomyosarcoma.
Why? Why you mention it as a top?
bladder mass في البيدياتريك.
Pediatric bladder mass. It can be sarcoma. It can be also what? If I show this one and this one on ultrasound without this, what you are describing, we mentioned one of them very similar. I will just show you. I hope that I can find it easy.
ECC.
It can be sarcoma as a tumor. If it's not tumor, it will be what?
Hemangioma.
Maybe, or I show you one case. I just try to find it. I hope it's
Hemorrhage clots.
Hemorrhage clots, perfect.
Hematoma.
It can be hematoma. So don't just go for just one diagnosis. It can be this one or this one, but I try to find it while I'm talking with you. Yes, it can be hemorrhagic cystitis, which have sometimes similar appearance. It can be also the one we mentioned here. It is tumor, which is mass in the bladder. It can be sarcoma, and the most common type it is rhabdomyosarcoma. Okay. Okay. I did think that I think it's here. Yeah. So this one, it can be something called hemorrhagic cystitis, and sometimes, but it look like a bit bigger patient, or older patient, but it can be something like hemorrhagic cystitis. But when you find a mass in a pediatric patient, almost you are talking about rhabdomyosarcoma, especially if she show you like this one. Yeah. So ultrasound, the bladder anechoic, pediatric patient. So solid mass projecting in the bladder, young. So you are talking about what? Talking about rhabdomyosarcoma. They can show you also this, like in the X-ray, with filling defect. Okay. The most common pediatric soft tissue sarcoma. It can happen everywhere from the kidney until the bladder. Very malignant. Yeah. So this one, it is rhabdomyosarcoma. I showed you this before in the chest revision. So if it is a young patient and you find consolidation, you will mention anything, but don't forget what? Yeah, Marwa, don't forget in the differential what?
Collapse.
Yeah, primary TB. Don't forget primary TB. Yeah.
Don't focus.
Yeah, and yeah, I agree. Bogon's focus, and if you can see this. Okay. Again, don't look in this one. Look just in this one now. Dilated bowel loops. You are talking about obstruction. In your approach, is it high or low? Then, when they give you the enema, what do you describe? It will be the last case because we have just less than 1 minute. So it is
Meconium black syndrome.
Meconium black syndrome. Yeah. Functional immature colon, and don't forget we mentioned already this diabetic mother. Okay. Multiple filling defect in the left colon. The rest is normal. Meconium, yeah, unused left colon, and they have this description, new description, yeah, unused left colon. Okay, thank you, Iman. Thank you, everyone. I hope that you enjoyed this today. See you inshallah next Saturday. Assalamu alaikum.